Can we start?
Yes, please, sir.
Okay. Good afternoon, everyone. So today we are having a health talk on the topic of interventional pulmonology, past, present, and future. So we are at Parul Institute of Medical Sciences and Research at Parul Sevashram Hospital. We have a full functioning department of respiratory medicine, which deals with diagnosis and management of all types of respiratory diseases and disorders. So since last 2 months, we have started a interventional pulmonology department, which provides us dedicated services in the field of interventional pulmonology, all basics as well as the advanced interventional procedures in the field of bronchoscopy and thoracoscopy. So right now in Vadodara city and district, we are the only institute to have a dedicated full-fledged interventional pulmonology department with all kinds of advanced as well as basic services. We have Dr. Amit Dave here with us. Dr. Amit Dave is interventional pulmonologist practicing since last 6 years in Vadodara city. He is an esteemed chest physician, bronchoscopist, and all advanced procedures he is doing successfully since last 6 years. He is DTCD from Ruby Hall Clinic, Pune, and he has done his DNB in chest from Calicut Chest Hospital, Kerala, and he has attended many interventional pulmonology workshops, and he has been the guiding light for us today for this health talk. So, Dr. Amit, can we start? So we have Dr. Amit Dave, consultant pulmonologist and interventional pulmonologist. Over to you.
Hey out there. Good afternoon, everyone. I hope am I audible and visible properly. Thank you very much, Dr. Yatin, for kind words. And yes, we are the only department. We have a separate intervention pulmonology thing, and I think we are the first in state to acknowledge this facility. Let's, without wasting time, I will start with my presentation. I am going to share my slide. So I hope it is visible now, and I will make it full screen. Can anyone tell me that it is visible? Okay. So what is interventional pulmonology is? Let's look into the airway. What we in basic science we tell is that we should look inside the body cavities and all viscera which we are diagnosing. And interventional pulmonology is a broad spectrum science, and it's the upcoming science. Today we are going to discuss about most of how it started, what is the history, what we are doing current now, and what are the future perspectives. So here we go. So basically my today's talk objective are to outline the history and evolution of bronchoscopy in the field of intervention pulmonology. What is the current scope of what I do specifically in an intervention pulmonology? And I will give few clinical case in between then and examples to just show you that's how we are working in intervention pulmonology and what could be the future of intervention pulmonology. If time permits, that we do a thoracoscopy with cases in a last session. So to give you the idea of intervention pulmonology is basically evolving field which has concentrated on lung and lung related procedures. It could be a malignant, it could be a non-malignant airway and parenchymal disorder, and intervention bronchoscopy usually compromise three domains, what we called as a malignant, non-malignant airway disorder, and artificial airway. So basically intervention pulmonology or interventional bronchoscopies procedure are basically to give a good diagnosis to the lung disorder and possibly novel therapeutic approach toward the lung disorder. So pre-endoscopy era, the way back in a time of Hippocrates in 1916, if we say that the Hippocrates, we do take oath of him, he has suggested to introduce of pipe into the larynx in suffocating patient. So the procedural related, the documentation is way back in 460 before crisis. It has been documented. In 1700, Salt advised nasotracheal intubation in the treatment of suffocation and removal of the forehead. So this how started the development of the endoscopy, where in Potter 1839 has stated that there is a perhaps of known to disease covered by the greater darkness or posing more difficulty to the practitioner than those of larynx and trachea. Because until then, the larynx could be only insufficiently inspected by the forcible depression of the tongue with the scapula. So before 1813, it was a just spatula, which used to be called as a glossocartocom to see the, by depression of the tongue to see just larynx. So this how evolution is occurred, and the most advanced bronchoscopy is way back in early 90s. But these three things are most invention that occurred in a major outbreak of intervention pulmonology. First, number one, instruments for inspect the lung airway, suitable light source, because as I stated in 1813, or Osler stated that the darkness in the hollow organ should be enlightened. So suitable light source and sufficient anesthesia to tolerate the procedure. These three novel innovation more further expand the horizon of intervention pulmonology. And this was the first endoscope to see. Can you see those rigid tubes and light source with the bulb? This was the picture I found in a way back, almost 18 or 1900 textbooks, which had shown. And this, the man is a father of bronchoscopy and bronchology, Gustav Killian. He has performed first tracheostomy with a capsule electrical handle for illumination of light in his bronchoscope. So that's how intervention pulmonology is started. And this gentleman, Sigeta Ikedia, is also a modern day father of bronchology, who had invented the first prototype of flexible bronchofiber scope. And he authored these semi-rigid and flexible tubes to insert in the lung airway. So this how we invented from tracheobronchial tree to up to the segmental and subsegmental anatomies. So coming to the intervention pulmonology back, there is a vast domain, as I mentioned you, that it has been used for diagnostic purpose, it has been used therapeutic purpose, and more of recent advantage like lung volume reduction surgery can be done in the endoscopic way, and intracranial therapy and cryotherapy, I mean to say, and thermoplasty, novel therapeutic approach for chronic severe asthma and all those malignant tumors has been evaluated in the name of intervention pulmonology. What is the spectrum which I am talking about? Is a flexible bronchoscopy, can be a diagnostic endobronchial biopsy, transbronchial needle aspiration, endobronchial ultrasound, what we call is a novel instrument, EBUS. There are lots and lots of therapeutic approach, balloon bronchoplasty, balloon dilatation of stricture of the trachea, endobronchial heat, argon plaza, electrocautery, photodynamic therapy, and so many things, and artificial airway, which I already mentioned, that in the form of metallic shunt and bars. Rigid bronchoscopy have a same structure by doing a debulking of central airway, obstructing benign or malignant tumors. All those photodynamic and cryotherapies can be done, can be put by artificial airway, by stent and Q-tubes, and all those artificial airway can be placed in the field of intervention pulmonology. So what I am going to discuss one by one, there are plenty of procedure we can offer in the form of diagnosis as well as therapeutic picture. So there are, I usually divide in them basic bronchoscopy or basic intervention pulmonology and more of advanced intervention pulmonological procedures. So I think you guys know about airway examination and simple fiber optic bronchoscopy, be it a video or a bedside naked eye bronchoscopy, to do a airway examination and to take a bronchoalveolar lavage to get a lung prolapse in non-resolving pneumonias, in complicated pneumonias, and all those thoracoscopic biopsy and thoracoscopic pleural drainage. All those are very basics. But where start a therapeutic intervention bronchoscopy is first is a basic in ICU mucus plug removal, all those cytology, brushing, taking a protective brush, taking an endobronchial biopsy, taking a transbronchial biopsy, taking a transbronchial needle aspiration. There are two ways. One can be done conventionally, transbronchial needle aspiration. Other can be done an endobronchial ultrasound. Endobronchial ultrasound procedure we will discuss later on today. It's a more advanced bronchoscopic system and which required highly skillful hand to perform those advanced procedure. Autofluorescence, external navigation, electrocautery. You can do a electrocautery basically at you guys are doing in a surgical procedure. Same you can do organ plasma, photodynamic therapy, cryotherapy in or central benign stricture, benign masses of central airway and malignant masses of the airway and thoracoscopy, obviously. So let's start. I am not going to discuss a basic thing like taking an airways examination or BAL and all those things, but let's start with this case with showing that entire left side hemithorax is opaque and all bronchus cut-off sign. I got a early morning call somewhere around 4:30 and 5 o'clock. That patient is succumbing. X-ray is showing entire hemithorax. It is a pleural effusion which filled up just within 2 days. No, it was a huge mucus plug. I had to rush to the ICU, take my bronchoscope with me, intubate the patient and clear out all the secretion. And you can see the post procedure X-ray, which is showing complete expansion of the left lung. What I want to try to say is that it's not a simple bronchoscopy or diagnostic procedure. It's a therapeutic procedure where the mucus plug in ICU setting is a normal phenomena and normal complication in cerebrovascular patients and dementia patient and aerobic NCAF patient. All those things can be removed nicely from the lung and it called as a therapeutic bronchoscopy. And many times this is a life-saving procedure in the field of intervention pulmonology. And to be frank with you, it's the most satisfying because once you get lung expansion, your patient will start a normal breathing, patient start a normal ventilating, and it's the most satisfying intervention pulmonology procedure. So I was talking about transbronchial needle aspiration, conventional as well as endobronchial ultrasound. So what we can do is that in that you have a huge mediastinal mass. Can you see in the CT scan? This patient came to me with a huge, but you can identify the airway. Trachea is visible. There is no airway cutoff sign. The lung is visible. It's entire mass in mediastinum. So when you got this much huge mass, you can just put a needle through the bronchial wall in a subcarinal or carinal spaces and do a jabbing or hot up method and take a cytological sample like you are doing in a FNAC of outer lymph node. The same thing you can do through the bronchoscopy. So again, it is a basic interventional procedure which we called as a conventional transbronchial needle aspiration. Another way of taking this advantage of your OT, that if you do have a fluoroscope in your OT, you can take under the guidance of fluoroscopy in two ways. You can take a transbronchial needle aspiration of the same mediastinal lymph node or a mass by under the guidance of fluoroscope. If you do not have a luxury of endobronchial ultrasound, you can utilize this method also, where you can take a simple cytological sample through the bronchoscopy under the guidance of fluoroscopy. So you will be able to localize your needle where it is going in the mediastinum, whether it is going in the lymph node or a mass, whether it is going into the heart. So you can visualize your method. Another procedure you can do use a fluoroscopy is a transbronchial lung biopsy, where in diffuse parenchymal lung disease or peripheral mass where you want to take a lung biopsy or a mass biopsy, you can use a fluoroscopy as a guidance to open up the forceps and take it as a biopsy. So basically, these are the conventional things which we usually do. But the advent of endobronchial ultrasound, the first endobronchial ultrasound in India came in somewhere around 2008. So it's not very early came to the India. But if endobronchial ultrasound you want to perform, you should thoroughly have this anatomical knowledge of regional lymph node anatomy. They are divided in superior mediastinal node, aortic nodes, inferior mediastinal, all, and they have a station from 1 to 14. I'm not going to teach you this anatomy in this short span, but you have to be thorough this node anatomy to perform endobronchial ultrasound. What the instrument usually look like? It's a basically endoscope with a dead end of ultrasound processor, and it called as a linear probe. There are two types of probe in endobronchial ultrasound is possible. One is a radial, which has a forceps-like structure, and one is a convex or linear probe, which is a real-time central lesion, and you can access all those stations, particularly 2, 4, 5, 6, 7, which I showed in the previous slide from 1 to 14. So these two types of instrument and how it looks basically diagrammatically, if you see that you go inside with the your ebuscope, you inflate the balloon, you touch to the wall of bronchial airway and inspect the mediastinal anatomy of the lymph node. By analyzing the lymph node, by localizing lymph node, start doing a needle.
I think there is some technical problem because of the slow internet connectivity. So Dr. Amit Dave has been disconnected. Just wait for some time. We will try to get him back in the webinar. Can you hear me?
Okay, I am
yes.
back. I am back. Just 1 second.
Yes, yes.
Okay.
Dr. Amit Dave is back with us. Let us resume the webinar.
So you can see my on-screen image of ebuscope, endoscopic, the A image. I'm so sorry for that was an internet issue. And we started from this slide that I showed to ebuscope. And the next slide is showing 4 images on your screen, which A image is showing the endoscopic view. B image shows the subcarinal node of CT view and how you look it into by attaching the linear probe to the bronchial wall, and this kind of ultrasound image you can visualize. So somehow it looks like same. Okay, so okay, so can you see that ultrasound images and needle? Okay, so it looks like this. So I will show this is the node. You have to measure it, and below you have to do a Doppler analysis and identify the vessels below the nodes, and then you can put the needle in the node. I will play for you a video. It is showing. So can you see the movement of needle? So that's how you take a sample, by doing a jabbing needle in the lymph node while doing a bronchoscopy. What I am doing is a simple jabbing technique in the lymph node. Just you have to be very skillful in this, because just below the lymph node needle, you will have a pulmonary artery. So that's how we do a EBUS sample. After removing the EBUS, we go for a Rose rapid on-site analysis under the microscope, and we will get the result. What is the autofluorescence? Autofluorescence is nothing but a light emitting study where you can do a simple light bronchoscopy. It will look like a images, and then if you do a autofluorescence, you can identify specifically endobronchial carcinoma in situ, those white reddish patches in the green light, and therefrom you can take a biopsy. For that, you require advanced bronchoscope, which have a autofluorescence or a narrowband imaging technique. So it's a simple imaging technique. In your mobile, you can take a snapshot and you modify the same thing we do endobronchially. We do a narrowband imaging study. We do identify the mucosa or submucosal carcinomatous deposit, if any, and we take a biopsy from there. So it's called a autofluorescence or another most advanced, and this is not yet present in India fully. Few centers I know that they are performing this, because the instrument called it as a navigational bronchoscopy is too costly, and in Gujarat we do not have a yet, but it's very simple, where you have a peripheral lesion, the CT scanner which guide you through the bronchoscopic tunnel, through the airway, till the lesion where is seated, and you can take a biopsy while doing a CT scan through the bronchoscopy or radial bronchoscopy. So that's called as a navigational bronchoscopy. Electrosurgery, it's basically electrocautery with argon plasma coagulation, Nd:YAG laser, and cryotherapy. So these are the probes, endoscopic probes, bronchoscopic probes, which we put up through the channel, and we remove those huge endobronchial tumor. You can see in the picture A that a huge left main bronchus tumor, which we have debulked while using all those modality, cryosurgery, electrocautery. We cauterize the tumor, we burnt it inside the airway, we remove with the cryo extraction, and then we put a stent. So can you see the blockage? Left main bronchus has been completely opened up in the B, and after putting a stent, it was recanalized. Argon plasma coagulation is nothing but a simple coagulation device where you can coagulate this tumor and minimize the risk of bleeding inside the airways. If suppose such kind of patient comes to you who has a huge bleeding endobronchial tumor, where we use argon plasma, it's a laser beam type fumes which comes out of plasma, and it cut nicely and coagulate meanwhile you are doing the endobronchial debulking. So these are the laser technique where you can just do a laser cutting of endobronchial. All these things has been done very skillfully, and we are doing specifically I have done more than 50 debulking so far in my last 10 year of interventional pulmonology. Cryotherapy is nothing but freezing the tissue and take it out as a biopsy. Cryotherapy has a lots and lots of things that it doesn't damage. Electrocautery, argon plasma, and laser beam usually damage the tissue architecture. So cryotherapy is to extract tumor particles. Apart from this can be used as a cryotransbronchial lung biopsy, because it doesn't damage the lung parenchyma. But the complication in this cryotherapy is a bleeding, because it doesn't destroy the parenchyma, and it comes out as a huge bleeder in the airway. So you need to be so much skillful to do this all procedures. We are doing cryotherapy since 2018, and we have a lot of cryobiopsy in a diffuse parenchymal lung disease where you cannot identify between which kind of ILD that we are taking a cryobiopsy, and in malignant lymphangitis, carcinomatosis, AML, post chemotherapy problem, we are doing all those as a cryobiopsy. Another futuristic approach of bronchoscopy is the bronchial thermoplasty, where we do a cauterize or just burn the airway, constricted airway in severe or very severe asthma to dilate the airway apart from bronchodilator therapy. So what is the bronchothermoplasty? What I mean is that in very severe asthma or obstructive airway disease, when your severe bronchospasm, which is not relieved by giving all types of bronchodilator therapy or all types of biologic therapy, omalizumab and all those things, still your asthmatic patient getting severe exacerbation, still your COPD patient getting severe exacerbation repeatedly, you can definitely go a therapeutic approach as a bronchial thermoplasty. It's altogether entire a separate lecture on the thermoplasty. But I just wanted to give you the glimpse how we do. We go with the bronchoscopy, we identify the stricture or asthmatic airway, and we just burnt out them to make smaller and dilated airways. So I had talked about stenting and artificial airways. So there are two types of silicone and metallic stenting. You can see the plenty of manufacturer has been producing silicone, rubber, flexometallic, combined single standing, woven, all type of stent. Where do we use this standing? I already shown one case in previous slide is that we do debulk, open up the airway, we put the stent. Otherwise, tracheoesophageal fistula on those all C esophagus cases, and all these things are we do remove tumors and not benign strictures, and after that to open up, expand the lung, we put a stenting. See, you can see in this image the entire that left main bronchus was debulked and put a metallic wire stent which open up the distal airway. So placement of endobronchial stent are a highly skilled procedure. It required a combination of rigid bronchoscopy as well as flexible bronchoscopy. Another novel approach in the artificial airway is a one-way endobronchial valve, which has a valve-like mechanism, which used basically in bronchopulmonary fistula patients and severe emphysematic chest, where you can put this valve and the air is going in, not going in, and easily comes out all those secretion and trapped air from the severe emphysematous chest. So these are the novel techniques, usually not possible in our Indian continent. Nobody has performed from us these valves because these valves are very costly. And to be frank with you, the advantage by putting this valve in severe COPD patient is not outweighs their quality of life. So in India, it is not yet available, but soon they will come. Balloon bronchoplasty I was talking about. So it's a very, very simple procedure, and we usually do it via flexible bronchoscope or rigid bronchoscope to open up the airway, stricture airway. I will show one my case that you can see the CT here, where just above carina, where through a very small stricture, grade 4 stricture has been occurred. It was a benign in nature. And what we do is we do a simple bronchoscopy, just a 4 mm stricture, which identify sequentially balloon dilatation, and we open up the entire trachea and visualize the main carina and subsequent distal airway. So a few last 5 minutes regarding thoracoscopy. In absence of time, I just want to skip the history. But what we do is a medical thoracoscopy. What is the difference between BATS? It's a video assisted thoracoscopy, and medical thoracoscopy. That medical thoracoscopy usually is a diagnostic procedure, and video assisted thoracoscopy, which we do, is a basically therapeutic procedure. Instrument are usually flexi-rigid bronchoscope or rigid thoracoscope or flexi-rigid thoracoscope. For medical thoracoscopy, it doesn't require a complete general anesthesia. It can be done like you are putting a ICD in a local anesthesia. It doesn't require intubation. It doesn't require a specific OT. It can be done in your bronchoscopy shoot or an endoscopy shoot. Usually we put a single port entry through the ICD or via trocar, and it's a very safe procedure as compared to the VETs. There are lots and lots of indication, but the most important indication is the undiagnosed pleural effusion, staging of the lung cancer, staging of diffuse malignant mesothelioma, and pleurodesis in the CA lung patients. So basically, we do those thoracoscopy to get a diagnosis. These are the equipments for the rigid thoracoscope. This is called as a semi-rigid pleuroscope or thoracoscope, which is similarly like a bronchoscope. You can use that. And how we perform the technique, I'm not going to in detail, but the most important complication you should aware about that desaturation is less than 2%, post-procedure leak, bronchopleural fistula or alveolar pleural fistula somewhere around less than 2%. And yes, subcutaneous emphysema can occur in those therapy. I'm just going through this case. This is a 46-year-old gentleman who was diagnosed with pleural fluid, but no tumor cell, and recurrent effusion, which I did a thoracoscopy, and the endoscopic view was looking like that. Lot of septi, the white deposit on pleural space, and I got the diagnosis. On thoracoscopic finding are most of inflammatory pleural changes and fibrin deposit and white spot. I took a biopsy, and biopsy shows the granulomata with epithelial cells and necrosis. Usually this kind of picture when we see in a pleuroscopy, it's more of, can you see the third image, that those patches are classically known as a Chagrin patches, and it is a more of endoscopic image of tuberculosis, which was confirmed in the histobiological diagnosis. Another 65-year-old lady, which already known case of a breast cancer, had a pleural effusion multiple times of cytology negative, did thoracoscopy, which was pleura looking like this. So can you spot the difference between inflammatory pleura in the previous case? It's very smooth Chagrin patches and fibrin exudate, and here you can see highly vascularized pleura and lots of deposits. So all those are tumor deposits. I took a biopsy. We called as a confluent tumorous lesion, frequently seen especially in the metastatic breast cancer, and biopsy suggested metastatic malignant pleura, which immunohistometry had too. So these biopsy we do, why that we can get a molecular diagnostic. A HAL2 positivity has a very good role of the chemotherapy. So malignant pleural involvement due to breast cancer, and it will be easy, like simple. When we send a blood culture or sputum culture examination and we got the organism and antibiotic sensitivity, we give that sensitive antibiotic and it get results. Similarly, if we do a pleural biopsy, we get a ISC done and we get a immunohistology analysis done and we get a receptor analysis done. If we found a positive, the specific chemotherapy can be given such kind of the patient. Another case which I have seen, the thoracoscopic image, which has a lots and lots of exudative. So can you spot the difference between first case and this case, is that there are a lot of fibrinous exudate. It's called as a typical empyema loculation. Another this thoracoscopic image, which is very well known, it's called as a pleural or a small bulla, apical bulla, which we usually just clip them or just brushed them after suturing. This is the large bulla. Actually, we can remove this small bulla. Such a large bulla has to be removed by the surgeon. So this was the giant bulla, which I asked my cardiothoracic colleague to remove. And this was the smallest bulla, which I removed with the clipping of the thoracoscopic guidance. This is another case which was difficult for me. It was a schwannoma of a reed. I took just a biopsy and referred to the surgeon for the chest wall defect and surgery. So it was a benign. So what is the takeaway message? That focusing on application of the any new development procedures or bronchoscopic treatment in a various aspect of all those lung or airway disorder, basically all those malignant and non-malignant airway disorder, the advantage of the any technique, it should be a diagnostic value as well as therapeutic value. All those first line basic intervention are a good or immediate result can give, and trust me, they are very, very safe as compared to the other modality. Broader vision or your horizon and to get a tissue diagnosis in any lung disease will help you to manage in a better way of the patient. Thank you very much. I am signing off and over to you, Yatin bhai. If any question, please ask me. Free.
Hello. So we had this beautiful presentation on the all.
Thank you.
Wonderful presentation on this newer kind of our branch. Please, everyone who is watching this on Facebook, we have a dedicated department with all interventional pulmonology procedures available. That's always welcome to refer patients for any respiratory pulmonology. Thank you very much.
Thank you very much, everyone. Thank you for joining. Thank you, Yatin bhai. Thank you, Kalpesh bhai. Bye-bye.